will begin today's webinar for the launching of the new application for cardiovascular risk. We would like to extend a warm welcome to all the participants. Please close your microphones. Thank you so much for connecting on time. We know that your schedule is very busy, and we are grateful to have you here with us today. This webinar is broadcast simultaneously in English, Spanish, and Portuguese. If you want to listen to the interpretation, please go to the lower part of your screen and you will see the language of your choice. This webinar is also being broadcast through YouTube. If you have any connectivity problems, please go to the channels of YouTube to continue. We are ready to begin. I would like to give the floor to Dr. Pedro Ordúñez to officially start this webinar. Pedro, please connect your microphone. Good afternoon, dear colleagues. I am Pedro Ordúñez from the Pan American Health Organization in Washington, D.C. It is a pleasure to greet all of you who are connected here today for the HEARTS webinar. We are going to be launching the new improved cardiovascular risk calculator application. My greetings to primary health care workers and teams from the 16 countries that are connected, and there are about 800 health centers connected too. We will begin now by saying that at the beginning of this seminar, our thoughts are with all the colleagues who are on the first line of care, taking care of the population. Without further ado, I would like to present the program that we have for today. We have 438 participants connected to the webinar. And also, I would like to ask the colleagues here in support to begin the slide presentation. We have a program divided in 3 blocks. The main dish is the launching of the new improved cardiovascular risk calculator application. And this is what we will be using in the HEARTS program. So the first part of the webinar will be devoted to presentations from one of our countries, Peru, that has implemented this tool, and Peru will show us the advances in this field. And the second part of the program will present the calculator itself. We will see this in our phones and our computers, but then what is behind all of these programs? So 2 experts will present on that, and then in the third part, we will show you how to download this application and this calculator. Without further ado, I would like to greet again all of you. We have almost 500 participants here. So I will give the floor to Jorge Janco, who is the technical director of the HEARTS in Peru. Jorge, you have the floor. Hello, good afternoon, and thank you so much for your invitation. We will be presenting the advances in the HEARTS initiative in Peru in 2019. We started with very important controls for the people who have hypertension in our country. The most significant achievements of HEARTS in Peru have to do with the model. At first, we have included a protocol for hypertensive patients in the national documents. And this dealt not only with prioritization of several centers, but also other centers. And we have several facilities that have joined and will be with us up until 2025. Also, it was imperative to have monitoring of the intervention in each one of the prioritized facilities. There were 34 facilities that were part of the initiative at the beginning, and we have seen what is the evolution of all the indicators. And also we have seen the effect of the pandemic in these centers, and we have been able to establish comparison. Also, we have observed that even though we have seen that several of our goals were not met, we try to reach a point of stability, and this point of stability was reached in some of the facilities. So also, we have incorporated several drugs in the protocol for centralized purchases and the projections toward 2022. Also, we have had contacts at the level of the Ministry of Health vis-a-vis these projections for drug acquisitions for 2022. And also, during 2019, when we implemented this initiative in the country, we reached several milestones in technical assistance and support for the purchase of validated digital blood pressure monitors. We have been given support, and we have emphasized that it's necessary to have these validated digital blood pressure monitors. And we have to make sure and actually have emphasized the term validated. And this was based on the suggestions made by PAHO, because people have to make sure that these blood pressure monitors are validated. So how have we applied the heart strategy during the pandemic? The pandemic has affected our country in an important way. So we have a center on control and follow-up of hypertension. We have been able to follow the situations in the different facilities so that we could evaluate the conditions of these facilities through interactions and point of care interventions. In June 2020, we approved a health guidelines about the comprehensive care of people with non-communicable diseases, and hypertension was included there. Also, this guideline also has some of the pillars that have been mentioned in the HEARTS initiative. In addition to measurement of indicators for the control of hypertension, we have also mentioned controlling diabetics and home delivery of drugs or facilities so that the family members of the sick person could go get their medicines. And we have followed this initiative for the past 3 months. And then, of course, care at that level is key to the success of the program. Of course, we just emphasize the measurement of these indicators. We have projections of expansion of hearts to 2025. We started in 2019 in September. And then at that time, there were signs that because of the work of PAHO, we could introduce this initiative. So Peru started this initiative with 34 accredited organizations. And then we hope to include at the end 198 health facilities that take care of the vulnerable population in Peru. We hope that in 2025, we will have 3,000 health facilities. And also that we will have added 40% of the primary healthcare facilities. We have learned that we cannot neglect risk management as a strategy to incorporate hearts. This is a very important part of planning. And this, of course, this implies personnel changes, equipment changes. We have to take care of the patients who are not with us anymore. And then everything that has to do with risk management to be able to identify any problems with coverage. Another thing that the pandemic has taught us is that we cannot have good health management in the different systems if we don't have patient registers for hypertensive patients. All hypertensive patients in these centers have to be properly identified. Political will is another decisive element for the implementation of the Hearts Initiative. We have to know what are the points of motivation and interest existing at these facilities. And of course, the academic sector and the role of the academic sector in intervention control is essential. And that is key to improving care in all of these facilities. And some final reflections is that we will never be tired of saying that monitoring is a fundamental element for decision making. And this is an essential pillar. The pandemic also has served as a point for reflection. We have reflected on the inequities existing in access to people with hypertension. We know that there are more vulnerable populations that have not been taken care of because of distance and because of other conditions existing in their daily lives. They cannot come to the health services. So this is a picture. I wanted to share this with you. We will be working hand in hand with all the health authorities. This is a very important initiative that has shown very positive results in the region. Here, over to the right, you see the Ministry of Health, and then the team of the Washington office, and we are presenting there the Heart Initiative. And we see also the representative of PWR office in Peru. And then over here, we see also the incorporation of the academic sector. The University of San Marcos have been here with the representatives of PAHO in Washington, D.C., and also the ministries and high dignitaries also. Thank you so much for your invitation, and we'll be happy to answer any questions. Thank you so much, Dr. Jorge Janco. As I said, he is the technical director of hearts, in charge of hearts. And he is the leader of the initiative in Peru under the umbrella of the Ministry of Health. Could you please turn on your camera, Dr. Jorge Janco, just in case there are any questions? So I wanted to remind the participants that we have simultaneous interpretation, English, Spanish, and Portuguese. And we have Portuguese because we are welcoming again Brazil. Brazil is a country that has introduced the Hearts Initiative, and we had the big surprise to know that Brazil had already appointed a technical group for coordination of hearts. And so this is an official establishment of the program in Brazil. Also, we have the participation of practically all the countries in the region. And therefore, I just wanted to make sure that Jorge Hanco is still with us. I don't see him. Jenny, can you please help me locate Jorge Hanco? Please? Jenny. Yes. Dr. Jorge Hanco is connected, and I am asking him to raise his hand so that I can activate the audio. Because a couple of questions have been sent to us, and I would like to read them before going to the next one, but maybe at another time. Yes, Jorge Hanco. Dr. Jorge Hanco is connected as a general participant, so we have to activate him. If you give me a minute. So these things happen in face-to-face meetings as well as in internet meetings. Can you please let us see you? Can you turn on your camera? Yes, his camera is on. Jorge, you know what? They want to know who is one of the best persons who implements this initiative in your country, in Peru. And we have a couple of questions. The first one is, you said that HARS has been used as a response to the COVID-19 epidemic. What do you think will happen after the COVID pandemic is controlled? What will be, what remains? What can we put in practice? Or what is going to happen after COVID? Yes, good afternoon, Dr. Ordóñez. Good afternoon, everybody. Two aspects are very important. Lessons learned from COVID. One positive aspect is that telemedicine has come here and is here to stay, to give access to many people that didn't have access before. And then in the new health guidelines, we have telemedicine services. So any health professional can follow up with their patients through telemedicine. And then that way we can identify risk, we can identify any type of problem in the hypertensive situation of the patient, and just to make sure that the services are available. And then the COVID has taught us that if we don't have registries, or at least updated registries, it will be more difficult for all of us to follow up. In the country, we have told people they can make use of the administrative databases, and that has allowed us to identify several problems and to see what type of medicine the patient is taking. Many people just consult on the telemedicine channels about drugs, and then that way we have been able to better control our patients. And so this is closely related to the indicators, and it is a big help. We see how our coverage is advancing, how our control is advancing. And I would say that this would be one of the main lessons learned from the pandemic, in which we have seen an improvement. Thank you, Dr. Jorge Hanco. My congratulations to your teams for the advances in Peru. I think this is very stimulating for the sites that have not joined the Hearts Initiative and other countries that have not joined the Hearts Initiative. Right now, we have 16 countries. And I think the Andean area of Latin America is covered in Ecuador, Colombia, Peru, and we have Bolivia. So the Andean area of South America is covered, and then Chile is also there in the HEARTS program. So congratulations to the Peruvians for your advances and achievements. And now we will go to the second block of discussion, which has to do with the launching of the new improved cardiovascular risk calculator app as an instrument that is sponsored by the Pan American Health Organization with the CDC from the US. And in this block, we will have two experts. They are world experts. At this point in time, Dr. Tom Graziano, please show your camera, assistant professor of Harvard Medical School. And Dr. Graziano is one of the best known scientists around the world about cardiovascular risk. And he's very famous because of his studies on the economic impact of cardiovascular diseases on the population. So we have a new guest today, Dr. Tom Graziano. Welcome to the webinar, to the HEARTS. And the microphone is yours, Dr. Graziano.
Thank you, Dr. Ordóñez, Pedro. And,
muchísimas gracias, Dr. Pedro Ordóñez.
And I welcome everybody who's joining this webinar throughout
Bienvenidos
the Americas.
Todos los que están asistiendo a este seminario virtual.
It gives me great pleasure to talk about this topic.
Es un gran placer hablar de este tema.
As Dr. Ordóñez has suggested, I have an
Como ha dicho el Dr. Ordóñez,
from an academic perspective.
Yo puedo presentar una perspectiva académica.
And particularly, we are hoping to use this
y en particular, esperamos usar esta aplicación
Argentina,
en Argentina,
trial sponsored by the National Heart, Lung and Blood
un ensayo clínico patrocinado por el Instituto Nacional de la Sangre, el Corazón y los Pulmones.
So I was asked to
y
talk
se me pidió
about,
que hablara
and the how of CVD risk assessment. Why do we do
sobre la evaluación del riesgo de enfermedades cardiovasculares
and
y el enfoque y los métodos que usamos.
The 2019 WHO Cardiovascular Risk Charts.
Particular, las cartillas especiales de estas
Let me begin with the why. I developed
Vamos a empezar con la primera pregunta. ¿Por qué hemos creado estas cartillas o estos cuadros de riesgo de enfermedades cardiovasculares? Primero, porque la carga de enfermedades cardiovasculares sigue creciendo.
The resources
y
to manage it are extremely
los
limited.
recursos son bastante limitados para efectos de control.
WHO has a commitment.
Y el compromiso de la OMS
50% of people at high cardiovascular risk on treatment.
50% del riesgo alto de enfermedades cardiovasculares, dar tratamiento a eso. Y luego evaluar ese riesgo.
Treatment of cardiovascular disease is cost
El
effective.
tratamiento de este riesgo, de enfermedades de este riesgo, es efectivo en control en función de los costos.
Previous charts were outdated.
Y los cuadros previos están desactualizados o son solamente para las regiones de altos ingresos.
So I won't share additional slides around the burden.
Bueno, no voy a hablar más de la carga de estas enfermedades.
Maybe less familiar to people is how little is spent on
pero tal vez la gente no sepa lo poco que se gasta en esto.
This slide shows that
en esta diapositiva
very little, less than 3% of funds
Mostramos que menos de
global health is
3%
dedicated to cardiovascular
del
disease.
presupuesto para servicios de salud se
Despite
dedica a
its
la
very
enfermedad
large
cardiovascular.
burden.
Y eso representa una gran carga de morbilidad.
This looks at, unfortunately, given that we have limited resources, how
Como tenemos recursos
poorly globally
limitados,
we have done at controlling different
hemos
cardiovascular conditions such
visto
as hypertension.
cómo
There are nearly 1.3 billion people in the world with hypertension, 1 in every 6 people, or nearly 1 in 3 adults. But just barely half of those people are aware of their condition. Only a third of the global population with hypertension is treated. Less than 10% of the global population has their hypertension controlled. Clearly, we must do more. And if we're going to do more, we must make sure that we are treating people at highest risk. Let me give you some examples here of why it's important to understand risk. On the left here, we have a description of a 44-year-old female, non-smoker, non-diabetic, total cholesterol less than 4, and a blood pressure of 159/85. On the right, we have a 60-year-old female, the smoker, non-diabetic, with an elevated cholesterol, but a blood pressure of 139/84. That would not be treated in guidelines that suggest only to treat over 140. What is the risk of the first person? Less than 1% risk using the WHO risk charts for 10 years of having a cardiovascular event, fatal or non-fatal. And this other person, prior to the guidelines or any guidelines that suggest treatment below 140, has a 10% risk or nearly a 10-fold increased risk. So this is a challenge for us to be able to identify people at high risk who may not be receiving treatment and making sure that they are receiving appropriate treatment. Now we're going to turn to the question of how, as we now understand it is important to why it is to identify people at high risk. And these are the methods that were used for the 2019 risk calculator by the WHO. First, we'll describe some of the populations that were used for the risk calculation development, the outcomes that were used and measured, the risk factors that were used to use for the calculation, the calibration efforts, and then the external validation of the model. For populations, over 375,000 individual participants without prior cardiovascular disease in different observational cohorts from the 1960s to 2013 were used for the cohorts. This is 85 prospective cohorts in the emerging risk factors collaboration for the derivation model. It involved data from patients from 79 countries. The data from this population was harmonized for risk factors and outcomes. And then the populations were divided into 21 global regions for the models. Outcomes. There was an idea that they wanted to be able to follow each of the cohorts for a 10-year follow-up at least, that there was follow-up for cardiovascular death, myocardial infarction or heart attack, and stroke in all the patients in all the cohorts. Risk factors, patients were included in the cohorts from 40 to 80 years. They had to have identification of sex in the cohort, smoking status, prior or current, systolic blood pressure. And then for the laboratory-based models, diabetes, history, and total cholesterol were used. And those two were replaced with body mass index for the non-laboratory-based models. For calibration, investigators used data from the Global Burden of Disease 2017 studies from the Institute of Health Metrics and the Washington-based group to estimate MI and stroke incidence for the 21 regions. We used country-specific means risk factors values from the non-communicable disease risk factor collaboration, and these were updated and validated for the 21 different regional models. For external validation, 19 cohorts were used, with those 19 cohorts represented over 1 million individuals who were followed for greater than 25,000 different cardiovascular events. So a large database, both for the derivation of the models and the risk equations and for the external validation. This is an example of the cohort for Southern Latin America, one of the 21 regions. The other 4 regions representing the Americas are listed here on the right: the Andean Latin America, Central Latin America, high income North America, and tropical Latin America. As you'll see here, this is the lab-based chart. So we have it divided by sex, smoking status, age. I have truncated here, for example, just the larger age groups and the younger age groups. Blood pressure and cholesterol status. And this is for people with diabetes, and there's a separate one for people without diabetes. And each of you're allowed to or able to calculate somebody's 10-year risk based on pinpointing each of these values. And we will obviously see later the use of this paper form converted into the digital form for the application. But it underlines the same principles of using the multivariate risk equations to identify these levels of risk. Sorry. So this is, the non-lab chart for Southern Latin America. Again, the only difference is it does not have data on diabetes, and it has BMI categories here instead of the total cholesterol values. So summary of the results. There's little heterogeneity in the hazard ratios across the studies or geographies with regards to any of the specific risk factors. There was good calibration and goodness of fit for the prediction models in all of the 21 regions. That there were differences in absolute risk and stroke and MI differed across regions on the basis of the fact that there are different levels of the risk factors in each of the different regions. For internal validation, the models were tested with a measure of fit with the C statistic, with a lowest value of 0.66 for men in the non-laboratory based model, to as high as 0.757 for women in the lab-based model. For those who are not familiar with these scores, if it's 0.5 and above, it's better than guessing. The closer you get to 1 is perfection. And in many of the cardiovascular risk prediction models, we see risk scores that are predominantly between 0.7 and 0.8 as the best that we were able to do with the risk factors that we have available. And so these performance in the lab-based model, both in men and women, were well within that range. For external validation, again, we saw the C statistics were between nearly 0.7 and 0.8 across most of the models and regions. Noted in the non-laboratory performance, it was excellent for those without diabetes, meaning that 85% of men or 95% of women correlated with what their risk would have been if they were using the laboratory-based risk score if they didn't have diabetes. However, for those who do have diabetes, the correlations were relatively poor, with 45% of men and 25% of women correlating with the same risk score in a laboratory-based tool. So that is a challenge for the non-laboratory performance in those with diabetes. As I mentioned earlier, the populations had different proportions of high risk of greater than 20%. In Uganda, only 1% of the population is estimated to be at high risk, using 20% as the cutoff, whereas in Egypt, nearly 16% of the population would have that risk. And those are the sort of extremes across the populations from the risk score. That completes mine. I will stop sharing and happy to answer questions.
Excelente. Muchísimas gracias, doctor Gaciano.
Excellent. Thank you very much, Dr. Gaciano, for such a complete presentation. I am asking colleagues to write their questions in the chat. The team is very attentive. I have received some. Now, I will ask them now to Dr. Gaciano. We have more than 500 individuals that are currently connected. I would like to send greetings to our consultants with hearts. I also see Vilma Irasol and Patricio Lopez Jaramillo. Vilma is in Argentina and Patricio is in Colombia. They are our hearts advisors, so it is a pleasure to have them connected and watching this video that is being broadcast live on YouTube. I hope there are many participants connected. Dr. Graciano, I have a question here. In Latin America, as we see in many countries, so far individuals have followed different risk scores. Some have followed Gramingham, others the American Heart Association score, whereas others have followed European scores, and some even have their own within the country. My question is, why do you believe that the risk table presented by WHO are valid for all of the countries? Because it is important to analyze the risk score produced by WHO. You have the floor, Dr. Graciano.
Well, thank you. It's a very good question and one that we often get. Let me start with prior to the WHO or any other countries using scores that were developed in high-income regions. The challenge for using those scores is that if they've not been calibrated for use in another country, then they can over or underestimate risk. They still had some merit or some value because even when they over or underestimated risk, the rank order was appropriate, meaning that the people who are highest risk, even if they're over risk, tended to have higher risk than people lower risk. So if you have nothing else but that, then it's acceptable to use it to start to differentiate between at least the very highest risk and the very lowest risk. But now we have opportunities to have ones that are specific for regions using populations from those regions. And that was the advance with the WHO effort, using populations from 79 countries so that there was representation in each of the 21 regions with cohorts from those countries. And so that I think that is valuable. Certainly an individual country, if it has the same quality of data and applies the same methods, could develop their own risk score. I think they would have to decide whether that effort was worth it rather than using the WHO application. But certainly with most of the countries where they do not have a cohort, where they had the length of time and good follow-up, then it's going to be more challenging. And using the one from the region, it closely approximates their particular region. And so I think it's advantageous to use the WHO risk application, whether it's the chart or the phone-based. So I think that's why this is a well-validated with large numbers of people with representation in each of the regions from countries that make up that region, perhaps not all of them.
Excelente, excelente. Muchísimas
Excellent. Thank you very much. So I think that we are now almost ready to say that we have in our hands a robust tool that allows us to analyze cardiovascular risk and analyze those individuals that are affected by cardiovascular disease. I would like to continue to say that we are streaming live and that we have more than 500 participants in the room. And I would also like to send greetings to our professors, Don Dempedi, who are also connected. Don has been very active in the HEARTS program, and Daniel Pinheiro, who is a new participant in the HEARTS program. We are very proud of him. And Daniel, who is a consultant, is also connected here. And we're also establishing a partnership to continue to implement HEARTS in the Americas. I would like to send my greetings to Patricia from the CDC. The CDC were one of the co-sponsors, in particular of the cardiovascular risk calculator, and I wanted to ask the CDC for this contribution. And without further ado, I give the floor to the second presenter in this block. Mark Chaffee is one of the founders of HEARTS. Mark Chaffee is a founder for many things, but one of them is HEARTS. He is really esteemed in Latin America and our audience. And Mark who has wide knowledge in the clinical management of patients with cardiovascular risk, will be talking to us as to how to optimize the use of the cardiovascular risk. We should not get lost, but how we can properly analyze this that was previously explained by Mr. Graziano. Welcome, Mark. Welcome home. Welcome to this hard audience that is always very attentive to what you have to say.
Thank you, Pedro, for that wonderful introduction. And it's always difficult to follow Dr. Graziano, but I will try my best. It's a pleasure to be here and to see lots of familiar friends and faces. And so Dr. Graziano gave us a great perspective about the technical aspects and the excellent reasons and the progress and the research around it. And I'm going to spin this and take what Tom talked about and move it into a practical use of these tools. I work on the other coast. Dr. Graziano's on the East Coast. I'm on the West Coast of California, still part of the Pan America. So it's lovely to be here. I want to say hello to the English speakers, hola to the Spanish speakers, hola to the Portuguese speakers, and bonjour to the French speakers, and hello to the Dutch speakers. I think we've got all the languages covered in the Americas. So let's go to the next slide, the first slide. And so let's talk about the past if we're thinking about how to optimize a tool. So in the past, and many of you, might still be living in the past, clinicians tried their best to treat patients, and we had very few standardized tools. And, that's what you have to do. And I think what happens in that case, when it's sort of everybody does whatever he or she thinks, is that you've got may have resulted in confusion amongst the healthcare workers. And then if the healthcare workers are confused, then the patients are likely to be confused as well. And as Dr. Graziano mentioned, it can lead to over-treatment of low-risk people and under-treatment of high-risk people. So let's hope that that's in the past. So we go to the next slide. So what about now? Starting on, well, I guess it's June 16th, 2021, mark your calendars. Now we have access to these great tools, both in paper and digitally in the Americas. And so now to optimize the tool, now clinicians and health systems have adopted tools to standardize and help prioritize people for cardiovascular disease treatment. So as we start to become more organized and more consistent, we can have improved confidence of our healthcare providers. And if the healthcare providers are more confident, then this can result in reduced patient confusion. And confused patients are not necessarily adherent patients. And so with reduced provider and patient confusion, things should be better. And then ultimately, we can think about systems that operate with the benefit of this tool. So while clinicians are looking at the charts or typing in the numbers, you can imagine a system which does this eventually in the future might do this for the population. It can help prioritize high-risk individuals for enhanced treatment and greater intensity and frequency. Next slide. So I think it's important when not to use a risk calculator. So here's sort of a practical tool. If someone is already high risk, then the beautiful thing about the calculator is that you don't need to use it. So you don't need to look at those little boxes, and you don't necessarily need to do a calculation, because people who are identified at high risk, we already know that they're at a high risk of either a first or secondary cardiovascular event. And we know that just based on simple things like if they already have cardiovascular disease, they're very high risk of having another event. So no reason to type in the numbers if you already know they're high risk. Same thing for ischemic stroke and peripheral arterial disease. And there's other conditions which are high risk. They're not technically secondary prevention, but the risk is so high, it's very high risk and almost the same or practically the same. And some of these diagnoses include diabetes or chronic kidney disease. And so because these risk tools say, hey, you know, that those individuals should be considered high risk, really, it's a time saver. And so I think really the risk tool comes in when there's a question about risk. And so when clinicians identify people already as high risk, that's when you shouldn't be using the risk calculator, or it's not particularly helpful. Let's go to the next slide. But when do you use the risk calculator? Well, it's when they don't already have something which puts them in a high risk category. So again, they would have to not have coronary artery disease, ischemic stroke, peripheral arterial disease, something like that. And they'd also not be a member of a high risk group, such as diabetes or chronic kidney disease. So those are the patients. It's really the patients when many clinicians and systems are wondering, what should we do with this individual or groups of individuals? How aggressively should we treat them? So let's go to the next slide. So I'm going to pause right there, and I'll be back later with some specific country examples. So I'll be quiet here and let Jenny and Pedro take over.
Muchísimas gracias, Dr. Mark.
Thank you very much, Dr. Mark Jeffy, for your very valuable advice. In particular, what do we do? Mark, this is something that we see in the region of the Americas, and that is to make progress in the health systems and also to guide them through primary health care. And these resources are excellent for the primary health care teams to be able to optimize management of patients who have cardiovascular risk. You know that one of the elements that we have been promoting is the use of the focus based on the health team. In addition to the doctor, we have properly trained nurses, we have other professionals, health professionals, and we think that this is a tool for them to contribute to assessing the cardiovascular risk. Then I would like for you to underscore the importance of this, because in many countries we're still sending individuals with cardiovascular risk to the cardiologists and the heart institutes, but we suggest doing this at the very first level of primary care. And since you have so much experience with Kaiser Permanente, that is one of the best systems we have in the world, could you give us some advice regarding this? Please go ahead.
Sure, Pedro. I think so. Number one, I have been using risk tools in many forms for the past at least 15 years. And I think the key to remember is something that Dr. Graziano said, is that, look, no tool is perfect. These are just tools to help us assess risk. And so I think waiting until we get a perfect tool, if we wait till we get a perfect tool, we'll be waiting a really long time. So these tools are great. And they're improved, and they're better than they used to be, and they'll probably be even better in the future, but definitely reasonable to use it now. The second thing is that my belief, both in my work inside Kaiser Permanente and also visiting other places in the United States and Central America and across the world, is that most of this risk assessment can be done quite easily and doesn't necessarily require the use of a specialist or at times may not even be necessary by a trained medical professional. Now, everyone has to think about their comfort level, because really we are taking risk elements which are available and plugging them into a formula and generating a risk. And so you can imagine a system where a doctor did this, that's fine. You can imagine a system where a nurse did it. There might be a system where patients can do it themselves. on a website and calculate their own risk if they know some of the information. Also, you could even imagine a system where this happened by a computer in the background. So once you develop risk, the interventions themselves are generally the sorts of interventions that happen in primary care settings all across the globe. And we're talking about, okay, identify this person for a blood pressure treatment, maybe with a lower target. So that's something that happens in, let's face it, that happens in primary care across the world. Most of hypertension control takes place in primary care, not at the hospital, not in specialty care. And also, if we're talking about other things such as attention to cholesterol, lifestyle changes, at times aspirin for people with established disease, many of these things take place quite well in the primary care setting. So I think Pedro is right when we emphasize that this tool really, I think it takes all the expertise of the specialists and it makes it available across the globe to everybody. And I'm quite confident that in your systems, you'll find after you use this, that this tool can really help in many places, especially primary care settings.
Bueno, excelente, excelente. Bueno, hemos terminado.
Excellent. We have concluded the second module, and now we're going to move on to the third one. What is the calculator? But as part of this second module, we learn what we have behind the calculator, what is behind the graphs, the tables, and digital solutions. And we also learn when to use the calculator, and in particular, the message by Professor Jaffe, that is when not to use the cardiovascular risk calculator. For the third block, I have the pleasure to invite Professor Carlos Taje, who has been advisor to the construction development of this calculator, and he also advised on the development of the calculator that PAHO created in 2014. Carlos is a cardiologist. He is a professor of cardiology in the Las Cruces Hospital in Argentina, and he will be kind enough today to introduce today this cardiovascular calculator. And we have many questions. Everything is being recorded. All of Heart's webinars are recorded and they are uploaded on Heart's web page, www.hearts in Las Americas and Hearts in the Americas in English. And there you will find all of the documents, including the recording of all of these sessions. And I know that some universities are already using these sessions as teaching material. So I would like to say hi to Dr. Ribeiro in Brazil and also our colleagues from Chile. They have already participated in several events by Hearts, but Dr. Carlos Taje, I hope you are already prepared to present how to use the cardiovascular risk calculator.
Buenos días, agradezco la invitación.
Good morning. I thank the Pan American Health Organization for this invitation and the honor to collaborate with Drs. Graciano and Jaffa. I will be presenting the new cardiovascular risk calculator. In 2014, we developed at the request of Dr. Pedro Ordóñez the change of these tables in the AMR region as part of a cardiac calculator that was available on the web and also in the Apple Store and Play Store. This was highly successful. In 2019, a new cardiovascular risk assessment was presented as developed by the World Health Organization with new risk-adjusted models for 10 years for acute myocardial infarction and then cardiac death. And stroke. The world was divided into 21 regions. The calculator was developed for patients with or without cholesterol, and we had 6 regions: South, Caribbean, Tropical, Andean, Central, and North, that covered all of the countries of the Americas. What are the changes in connection with previous assessments? First of all, we see 6 regions in which the Americas were divided, and prior to AMR-B, there was a change to how the ages were categorized. Instead of 10, every 7 years, from 10 to 7. Blood pressure moved from 4 to 5 groups, and the most relevant change is that the risk estimation is not only as low, moderate, or high, but now we have an accurate level such as 20% of the cardiovascular risk. They also developed a risk of the an assessment of cardiovascular risk that includes BMI, blood pressure divided into 5 groups, tobacco consumption, gender, and age without cholesterol. The challenge that Dr. Pedro Ordóñez set for us from PAHO was to develop a new calculator that encompass the 6 regions with and without lab data, that is to say 12 different calculators, and have it in 3 languages. It was also important to add, as part of this application, the progress made in the development of heart systems. We have concluded that task, and we are presenting the new calculator. This is the way it looks on the web, with all of the menu to the right, and here we have the validation process. We conducted 2 trials, and we compared the color tables to the calculator. We invited 12 professionals. We chose 504 random cases, 84 per region, 56 with cholesterol, 28 without cholesterol, and they accounted for each of the boxes in the color tables. And in the first evaluation, there were some mistakes. There were 2 mistakes with information and 1 in the formula. We corrected them in the first iteration, and in the second one, we obtained 100% concordance with the results from the colored tables.
How do we calculate this cardiovascular risk? Well, the first point is to select the country, because each country has a different table according to the region. So we have a menu with the listing of all the countries. And the second thing that we have to choose is the calculator that we're going to use, whether we know or do not know the level of cholesterol. So we will begin with a characteristic case in primary health care. We want to characterize risk to adopt adjusted measures for prevention. This is a male patient. He's a smoker. He is non-diabetic. He has 280 milligrams per deciliter cholesterol and systolic pressure 170. So we calculate the risk. And then already the table says he has high blood pressure, and in 10 years he has a CV risk of 31%, which is a critical level. The calculator proposes an alternative. What would happen if we would control the risk factors? If the patient would stop smoking and would take a statin to lower cholesterol, and if we lower the systolic pressure to 130. So in 10 years, the risk would be 11%. That is from 31% to 11%, that is 20 points of reduction. So this is a calculation which is relatively simple. From the conceptual standpoint, when we talk about 31% of risk, I think it is important to understand that if we focus on the correction of risk in 100 people, we would have at least 20 events, just like we would have here in red in the left-hand side. So this patient had high blood pressure, and in the calculator, we include all the recommendations for hypertension control in 12 countries that have protocols. In Argentina, it is suggested that you begin with amlodipine and then to go to losartan. The second thing it includes is behavior adjusted to cardiovascular risk. In this case, a statin, and for people with a higher risk than 10%, we think that this particular case had 31% of risk. Another approach for the use of the calculation is to see if we can avoid certain types of behaviors in low-risk patients. For instance, this is a patient, 50 years old, normal pressure, and the doctor says if that person has 230 mg/dL of cholesterol, maybe all his arteries or her arteries will be clogged. So this person has a very low risk. So it doesn't make sense to have a primary health care prevention intervention. So when we do not have the cholesterol value, we use weight and height. And then we have the body mass index here with high blood pressure, and then we have 15%, which is higher. And then what would happen if we would change the risk factors? The person doesn't smoke, and the person would lose weight. Perhaps 75 kilograms and systolic pressure 130. So the risk would be 7%, which is moderate. So it would go from 18% to 7%. So the calculator has other instructions. One, it says how to optimize this evaluation of cardiovascular risk, and then the instruction for the use of the calculator, and the meaning of cardiovascular risk. And also, it has an orientation as to how to measure blood pressure. This is a bilingual instruction, and it has a calculator, which is something in which you include your gender, age, whether you are Afro-descendant, what is your level of creatinine, and so forth. So it shows what is the glomerular filtrate. And then a calculator for the body mass index. And this is used when we use the table that contains the cholesterol information and the one that doesn't contain it. So we see the usual levels here in cases of obese patients. Obesity 1, you see the body mass index and what would happen if that person would lose weight. In the case of the countries without developed HARTS protocols, we propose a generic strategy starting with 6 initial points: anti-calcium and diuretics, and then other medicines. And then also with a system of combination of these medicines. At this point in time, the calculator is available in the web at the Apple Store and the Play Store, and we expect that you will be invited to use it. We believe it's a very important tool for primary health care, and it will help to face the challenges that we have in the region of the Americas by mortality through cardiovascular disease. Thank you so much. Thank you so much, Professor Taher, for this magnificent presentation. And now we will see how we use the calculator. This is available in the platforms. So this is a totally free application. And I would like to invite you to download it and to just distribute this to your colleagues. We have a lot of people connected to the webinar. Many of you will be listening directly, others you will hear it later, but share the good news. Send the link to your colleagues so that all of us can download this calculator. I have several questions, and then greetings for Dr. Taher, and then Professor Malchafi, who will give us several examples, because in this first part, we will go through a review and we will go through an exercise with Dr. Malchafi. But Virginia Molina, Miguel Mano, Maria Cristina Escobar from Chile, Victor Won in Panama, Mariguerra in the Dominican Republic, Nilda in Ecuador, and Diana Fajardo in Mexico. We have people connected from all the countries, and we hope that you can just spread the word about the calculator. I will give the question to Professor Taher. Somebody from Mexico said, from Sonora or for Chiapas? Why for Sonora and why for Chiapas? Why don't you say for Mexico? How does this work? Well, in reality, in PAHO's HEARTS page, there are two proposals for Sonora and for Chiapas. Therefore, we have taken those two proposals. We in Argentina, we have the Argentine Federation of Cardiology and the Association of Cardiology. So the HEARTS project finances drugs in each of these two regions. At the beginning, we respect the proposal that has been presented to us just like that. But I assume that these Mexican colleagues probably knows more about the topic than I do. Yes, Professor Taher, what we have to emphasize here is that there are two products. One is how to calculate this cardiovascular risk, but the other thing is the protocol, or the protocols for launching it. And then with a click, you can say, you select a country, you estimate the country for you, the risk for your country, but then in addition to that, you look for the current protocol used in your country following the HEARTS module or protocol. Yes, and that is the case of Sonora and Chiapas. Mexico is walking towards a single protocol for the entire country, but with the idea of not letting the program lose strength. We have to start with the drugs that they had initially. And so that's the way that they have configured it. So it looks like it is two different regions, but the thing is, the regions that have different protocols, and for that reason we have the two. But then when you talk about the country, whether the country is implementing HEARTS or not, you know it's only one protocol for the entire country right now. Brazil has a question. Rafael del Alba, who is also connected here, said that in some areas, the most vulnerable people are considered high risk. They are added to the equation. Yes, vulnerable people, because they have a lot of vulnerabilities, we consider them high risk because they have less access to health services. They have a lower level of education to understand the recommendation, because they are economically more vulnerable as far as access to the systems is concerned, and access to medicines too. So all of these factors combined for them to have less care, and for that reason, they have a higher risk. So the calculator is a help instrument. It does not substitute for medical advice. And I know Professor Taher has insisted upon that. It doesn't mean also self-medication. It means that it is a guide to make better decisions. So now I'd like to invite Professor Jaffe now to have another exercise with the use of the calculator. Professor Jaffe, could you please start explaining how we use this institute in the clinical practice? What are the advantages of using this? Thank you so much, sir.
Great. And I just want to again thank Dr. Taher for creating such a fantastic tool. And he and his team really had an almost impossible job, which was to not only take risk scores and present them, but also have them work and have them integrated with country, and as you saw in Mexico, some regional specific treatment recommendations. So I think that that's really remarkable. And so I think just want to emphasize Pedro's point that this calculator does two things. On the front end, it helps assess the risk, and as Pedro said, look, there's lots of things that, there's many things which might increase your risk, which aren't part of the calculator. And family history, socioeconomic status, other things are just, they're just really difficult to put into a calculator. So any clinician can, upgrade or downgrade someone based on the clinical context. And I do think that's important. But on the other hand, it's really a great place to start. So let's go to the next slide, please. So let's take some other examples. So here are all the countries, almost all the countries in PAHO, not all of them, but almost all of them. And you can see that you can click on any country. And what's really neat about it is that if your country has an adopted, nationally adopted specific treatment protocol, it will be there. And if there's two, they're both there. So that's really great, because many risk calculators out there, they give you sort of generic advice. And so it's really great about this tool. It's got both parts. It's got help you figure out the risk. And then if your country has some specific suggestions based on the drugs that are available in your area and the preferences of the local stakeholders, whether it's the ministries, the universities, so it's really great. So it gets you it gets you one step closer to treating that patient by giving you some more specific recommendations of things you might want to try. So let's go around the world again. We already saw an example from Argentina, but let's go 3 other examples. Let's look at Cuba, Barbados, and Colombia. So let's go to the next slide. So let's go to a primary healthcare clinic in Matanzas, Cuba. And this was from a few years ago when we got to visit there. And this is a great activity outside a public health center with some medical staff screening and checking some patients, some individuals in the community for their blood pressure. And you can see they're diligently writing, recording the information. So let's go to the next slide. Again, let's assume that for this patient, we know the cholesterol level. Okay, so that's the first thing you would click off. Excuse me, let's see, go to the next slide. And for this patient, we'll indicate the gender is male, the person is a non-smoker, the cholesterol level is 270, and there's no diabetes, and we've entered the systolic blood pressure and the age. And so when this is all entered in here, we'll go ahead and hit calculate and go to the next slide. And you can see again, just like the example from Argentina, this is a very high risk person. It's I love this calculator because it's not red, it's past red. It's redder than red, it's high risk, it's critical. So I guess that maroon dark color, that means, way past red. So I love the color scheme, whoever invented that. So let's go to the next slide. And just for an example, we do have the rainbow of colors here, from green. I call this the traffic light. Green is go, you're good. Yellow is, caution, slow down. Orange is, almost red. Red is hang on, there might be a problem. And then I love the color, which is, redder than red, even past red. And I guess we'll call that maroon, or I'm not even sure what color that is. So I think this is great. And I think the more you use this calculator, you'll get a sense of what this traffic light really means. And the more you use it, the more comfortable people will be in your clinic setting with how to rank people's risk. Let's go to the next slide. So this is all taken from the example, but the blood pressure goal for this individual would be, for average, or in general, average and low risk would be less than 140/90. For high risk, with the risk of over 20% for 10 years, or known cardiovascular disease, or known diabetes, or known kidney disease, that would be a lower blood pressure threshold of 130/80. And also, we're, treating blood pressure is important. A lot of what we do is talk about blood pressure, probably the most important risk factor next to smoking. But there's other things also. And so high risk people who have not yet had coronary disease, you could consider adding statins and then control their blood pressure. And people with known cardiovascular disease, you of course would consider a statin, treating blood pressure if needed, and then often aspirin for secondary prevention. And then also, I think it's important to recognize that the frequency of follow-up is actually described here in risk factor treatment, because high risk probably should be seen with greater frequency than lower risk. And the example here is 2 weeks. And, that would be every few weeks until things are under control. And moderate and low risk, probably less urgency, so more like monthly. Now, of course, these are all adjustable based on your local environment. But I think the main message here for the frequency is that, those at higher risk probably deserve a great, little more frequent evaluation and treatment than those at lower risk, which kind of makes sense. So let's go to the next slide. So this patient here, if we refer back to the prior slide, would be recommended to stop tobacco, take the appropriate blood pressure medications, consider starting a statin, have a target blood pressure of less than 130/80 because it's a high-risk individual, and then follow up in 2 weeks. And this is really just taken right off the tool. Next slide, please. So let's take another example here, and let's go to Colombia. And this is a primary care clinic in Pereira, Colombia. We visited a few years ago. And let's go to the next slide. So what we're going to do is, I neglected to mention it on the first slide, is we'll go up to the upper right, and you can see the Colombian flag there. And so we're going to select, of course, the country. So we got to make sure we select the proper country. So that would be Colombia, either by flag or by name. And let's suppose for this person, we do not know the cholesterol level. No problem, as Dr. Taller said. We can use other risk factors, which generally don't require any laboratory testing. So if you have a scale to measure blood pressure, and you have a scale to measure weight, right? And a tape measure to measure height, and a blood pressure cuff, automated and validated, of course, as we heard from our Peruvian colleague, Dr. Hanko. If you have that, then you can go ahead with the risk calculator, which is, I think, really terrific for places where access to labs may be a barrier. So let's go to the next slide. So we'll enter age, smoking status, diabetes, weight, height, and systolic blood pressure. And we'll go ahead and hit calculate and go to the next slide. And you can see this is a similar example to what Professor Taher said earlier, and that's that this is a very low risk individual. It's in the green, in the traffic light analogy, this is go. I mean, things are probably good, very low risk. And we'll go to the next slide here. Still an opportunity to promote healthy lifestyle interventions with a slightly higher blood pressure target of 140/90 and stopping, counseling about healthy eating and stopping smoking. But this person would probably be a lower priority than other people and would probably be assigned fewer resources than the other high-risk person. So let's go to the last example. And we'll go to Bridgetown, Barbados. And this is a picture from several years ago. And we'll go to the clinic there. And let's go to the next slide. And we'll start that. Hey, wait a minute. This person already had a heart attack. So we're ready to click. We're ready to go to the Barbados calculator. We're ready to click that flag. And then we have to remind ourselves, okay, this patient, I already know this patient is high risk because they've already had a heart attack. And so again, when we're training our clinicians and using this tool, it's important to let people know that this patient, we already know they're high risk, and the risk assessment tool probably isn't going to add a whole lot. So I'll go to the next slide. And then treatment for this patient on the left, because they are beyond red, right? They're over 30% in the critical range, that beautiful dark red maroon color. We'll say for secondary prevention with established coronary disease, it would be blood pressure medications as appropriate, consider a statin, consider aspirin. And then the follow-up would be more frequent, would be in 2 weeks until things are under control. So next, let's go to the next slide. So really, again, just to summarize, if person's high risk, probably okay to go right past the calculator. If they're lower intermediate risk, then the calculator can really help you identify risk. PAHO now has country-specific tools to help us identify risk, and equally as importantly, when available, to guide you to the country-specific recommended protocol with the treatment pathway and the medications that have been really advised by that particular location. And then as we think about this in the future, we're often doing this one at a time and having our clinicians do this one at a time. But in the future, you can imagine a system which might be able to do this for large populations, maybe even automated, to help start to identify systematically those people who should be prioritized for greater attention, and those people who may not need so much attention. And it really gets us back to the very, very beginning of the risk calculator conversation, which says really a risk calculator really helps us sort out who needs to be treated a little more intensely, who needs a little more frequent treatment, and who can be treated with a little less intensity. And it helps us assign the resources most appropriately in our healthcare systems. Next slide. So thanks for letting me talk to you today from foggy San Francisco. And it's great to see so many familiar faces and names, and I look forward to continuing to help on this journey as we identify those people who are at the greatest risk, and we offer them enhanced services. Thanks, Pedro.
Bueno, excelente, excelente. Yo creo que ha quedado muy bien ilustrado
Excellent. I think that we have had a perfect presentation of the main topics, how to use the calculator, and I am going to ask the presenters, the facilitators of this session, Jorge, Jorge Hanco, Mr. Graciano, Dr. Graciano, Mark, Carlos, Taher. I'm going to ask you to turn on the cameras because we have a great deal of questions, but we have no time for all the questions we have accumulated. But the truth of the matter is that I am concerned because someone said that the calculator is not working, and then when I downloaded it, I wasn't able to calculate. So I think that it all takes a learning curve. I hear that many have downloaded the calculator and it is working perfectly well. So that it means that if some were able to download it, certainly they will be able to make it work. The other question is, why do we only have 500 individuals? No one has left. Mark, Tom, 500 individuals. No one has dropped out. I think that they just closed the doors. No one has been able to leave the meeting. But my question is, why are we left with 500? And the answer is because this room only accepts 500, and we have received a very high number of messages asking how to come in because the Zoom room was full and individuals are moving on to YouTube where we are streaming this event. But I want to go back to Dr. Graciano, who is newer to our webinar. And Professor Graciano, what is your opinion about what you have seen with the calculator and what we have presented here? That is in the first place. And second, could it be that nurses, and I know that you are one of the main world leaders that is asking for support for the for the work of non-qualified individuals and also the work of nurses as part of medical teams. So, Tom Graciano, I'd like to know what your opinion is.
Well, first of all, I want to say thank you again for participation. And I was very impressed with the presentation on the use of the application. And as Dr. Jaffe said and Dr. Tayar said, that there are two different features to this problem of solving cardiovascular disease. One is the understanding and assessing people's cardiovascular risk. And as we said, there's some are very easy ways. Does the patient have heart disease? Two, the use of these applications or potentially other risk factors that Dr. Jaffe referred to. But most critical is once you've identified those people is understanding what to do for them. And the application that you showed was just displayed today where it's linked to each country's protocols. And there's some questions about Mexico, whether one region or another ought to be different. But that's the important part. Once you identify risk, different countries may choose within the HEARTS package or their own budgets, decide that they can treat certain levels of high blood pressure, certain levels of cholesterol on the statins. And that's where it really gets important. And then the final question is, who can help those people? And I think that's what you're alluding to in the last part of your question. And I firmly believe that we don't have enough doctors, cardiologists for sure, even general practitioners to make sure that we reach the billions of people who have cardiovascular risk. And so we must find ways to bring in the use of nurses or community health workers. In our own work, we are going to use the HEARTS app for the community health workers, help identify the people at risk, refer them to the clinic. The nurses can be helpful in trying to collect the cholesterol values and then present to the physicians that they exist in that particular clinic the opportunity to make the treatment decisions using this app or something similar to it. So that is, the first part is identifying people at risk. We've moved that far. The next part is linking that to, in particular countries or regions, protocols for treating those people at those high risk. They may be different from country to country based on resources. And then finally, who can help patients get access to those therapies? In different countries will have different ways where it has to be done by a doctor. Others will allow us to task shift to nurses and community health workers. And those discussions need to be ongoing in every country, I believe.
Muy bien, muchísimas gracias.
Thank you so much. Now we have come to the closing of this webinar. Today is June 18th. We have had an entire week. We are remembering our colleagues who are on the first line of work for COVID-19 in some countries that have different and difficult situation. Many countries have low rates of vaccination against COVID. The hands of the health workers are full. And then at the end of the day, those of us who are here today feel very proud of what we have accomplished in cardiovascular disease. But we know that there are many people with these diseases that are more exposed to risk of dying because of the pandemic. So based on all of this system, we have to make sure that we get good results for all our population. I would like to take advantage to thank the heart teams throughout the Americas. That's an enormous team throughout the Americas. If you connect all of your faces, if you put your cameras on, and all the sponsors of this seminar, we will just put all of this in the heart page. Now we will have the teams of communication. Now we'll have, Arancha, why don't we take a good picture so that people see each other together with Dr. Jaffe, with Dr. Taher, with Dr. Graziano, just to make sure that everybody is in the picture. Gloria, Jenny, everybody. I would like to thank Tom Bigna and also Dr. Hanko and everybody, the interpreters that have been helping us with this work, with the fabulous work. Yeah. So anyway, my heartfelt thanks to everybody, especially to the professors who have accompanied us today. And those of you who have listened to this have a commitment. You cannot leave the room right now. The commitment is to go and just give this calculator to your colleagues. Tell them that you can start working tomorrow and that you can calculate the risk of cardiovascular disease and that you have to go and find a protocol for treatment with the right medicine, with the right doses. But then somebody told me something else. Did you include non-pharmacological treatment? Yes, of course, of course. Yes, that is included. Secondary prevention of cardiovascular disease. That, of course, has to be included. So we are including everything, the links, wherever we can find information. Have a good afternoon. Have a wonderful weekend. Thank you so much for your time and a big, big applause to all of you. And then just now, music to end. To end, we are going to finish with music. Music and music. Maybe I'm confused. Yes, we do. We do have music. We do have music. Thank you so much. We will see you next month. Thank you so much.